Next speaker is Dr. Dinesh Talwar sir. He will be telling us how to read a normal retinal OCT and pathological changes in the OCT in various retinal disorders. Thank you.
So without any further ado, let's go back. We've gone through how you use the OCT for anterior segment and glaucoma. Now what about the retina? Well, the fact is that the OCT is the bedrock on which management of many retinal disorders is now anchored. And not only anchored the diagnosis, but also their management and follow-up. We have different types of OCTs. We have the time domain, which was the first one to come. That's a Stratus machine, which had around 400 scans per second. Then we had now the spectral domain, which is the workhorse. And there you have the OptoView, which goes up to 70,000 scans per second. And the Spectralis, which does 40,000 scans per second. And their axial resolution varies from 3 to 4 micron. And finally, now you have the swept source machines, which can go up to 100,000 scans per second and also have an axial resolution of around 8 microgram. Now, what is an OCT? The OCT is actually a real-time tomogram. It's a cross-section with false colors. So you can do it in black and white also, but either way, either pseudo colors can be used or black and white. It basically images the reflections from within the retinal layers to provide these cross-sectional images. That's because of interference at each level, and the different colors represent different degrees of light scattering from different depths of the retina. Now, if you look at this, this is actually like seeing a histological picture of the retina. Just like you can see the 10 layers of the retina on a histopath, you can see the same things in this, in an OCT. And in fact, for those who don't believe this, look at this. This is the histopath. You have the inner limiting membrane, and then you have the nerve fiber layer, you have the ganglion cell layer, then you have the inner plexiform layer, then you have the inner nuclear layer, the outer plexiform layer, the outer nuclear layer, the external limiting membrane, and then you have the photoreceptors. And you can actually see, what you see over here is the IOS-OS junction. Here is the interdigitation zone. So you are actually seeing a histopathological image, and you can figure out what is going on at every level if your machine is sensitive enough. And this is, of course, a Heidelberg machine. Not only can you do a qualitative analysis, which is very important because you need a morphological study to see how is the form, how is the structure, any difference from normal. You also do a reflectivity study. Is there any area where there's more reflectivity or less reflectivity, any shadowing? And then finally you do a quantitative analysis. How much is the thickness? Is there edema? How much is that edema? Is it becoming better? Is it becoming worse? You can tell all these things. In order to do this, you have various tools with the OCT. You can do a line scan, a raster scan, a radial scan, a mapping, and a volumetric analysis. Now what you see over here, you can see the normal profile. This is the normal depression. So the normal foveal depression. It's like a bow. Now, this is a line scan. Just one single scan is taken. Now, so you know what it looks like. But what if there was a lesion here? You would not be able to know what's happening. So a line scan is not good enough as a routine. You can even have an enhanced line scan. Suppose you want to see a particular area very clearly. So here, only this particular line, it shows you in more detail. But you want to see the entire retina up and down, so you use a cross line scan. So at least up and down you see. But again, you could miss something here. You could miss a lesion on the side. So what do? We then prefer to do not just the line scans, but also an overview. You see at the en-face image and see what is happening at every level. At the level of the ILM, at the level of the RPE, at the level of the inner limiting membrane. And then you want to do a more detailed scan. You see, each scan will mean more time. So if you just don't want to spend any time, the line scan was fine. But if you want to do as a retinal surgeon, this is not enough for me. So either we first used to do a grid scan, but then we realized even that is not good enough. The grid does give you at every level what is happening. But the best combination we found is a radial scan. So it's centered at the fovea and it goes all around. So I know what's happening in the entire area. And then to make sure I don't miss anything, I do a raster scan, which takes these horizontal lines. They can also be made, you can turn the orientation, make them vertical in all this, but every small distance is covered and you can see what is happening in the entire retina. Finally, you do a retinal mapping so that you shouldn't miss some area in the middle. So you're seeing the whole retina, you map the entire area, you know how much is the thickness in various parts of the retina, whether there's an abnormal part or not. Like this is what you see over here. For example, there's macular edema, and this maps out exactly the area of macular edema, also tells you the areas which are thinner. So both the things come out. You see that even better over here. You see this? This is, white means absolutely the thickest area, red is the next level, the yellow is below that, and blue means thinning actually. Now, just to show you practical utility, see, you cut through various sections, see each, and you know whether a particular lesion is there or not in any particular angle of the retina. The other important thing is what Dr. Sagarika was also telling you, you need to make sure that the scan is of good quality. So first you must identify both the inner and outer bands. You must have a good signal to noise ratio. Check whether there's any area which is getting truncated or which is showing shadowing or there's an abnormal profile. For example, this is not a good scan quality. This again, because of some opacity, you're not getting a good scan quality, but it's good. Supposing, for example, you have an advanced cataract, at least this tells you, no, this is not a normal retina, there is some macular edema. So if it was a diabetic, it tells you, look, it's not just a normal retina, but it's seen hazily. This is an area where, because of a blink, a particular area is not seen. Now, if this was the area where you suspect your lesion, you have to repeat the scan. This is not acceptable. When you see these kind of undulations, and they are at every level, from the inner to the outer, these are again because of movement of the eye. Now, the other important thing is you must make sure you get a foveal cut. Because there's a retinal thickening, you find you actually missed the fovea and you're just taking the retina below. So, go see the relationship to the disc, make sure you go through the entire area and figure out whether you've picked up a foveal scan or not. What about the regions? You have the preretinal region, you have the epiretinal region, you have the intraretinal region, the subretinal region, and then finally the sub-RPE. So what do you see? The preretinal is the area above the ILM. You want to see what is happening in the vitreous there. You can see in this one, there's a PVD. The epiretinal, at the surface what is happening? There may be a membrane there. You want to see what is happening, is it pulling? Intraretinal, whether there's a cyst there, some degeneration there. Subretinal, at the level of the RPE, what is happening? And that subretinal could be sub-neurosensory retina or sub-RPE. Both need to be checked. And what do you see within them? It could be some irregularity, it could be some fragmentation, there could be a rupture, some depression, some thinning or some thickening, just to show you. So the black space is normal. This is a membrane which shows there's a PVD happening over here. You see it even better over here. You see there's a PVD in this area. So above the fovea, you see the fovea here? Above this, there's a PVD. What about the epiretinal area? You could look for a membrane or an adhesion or traction, like you see over here. See, there's a membrane, but there's no effect on the fovea. Here you can see this is vitreoretinal adhesion with a membrane. And here you see this irregular corrugated membrane. So here, again you see adhesion. Here you see traction. You see it's pulled up. And that traction can be broad-based or narrow. Both can be picked up. Here you see a small preretinal neovascular membrane. You have to correlate it clinically, but you can see there's a preretinal neovascular membrane. Intraretinal changes could include edema, hard exudate, scar, atrophic degeneration. like you see here. So here you see a neurosensory detachment. You also see these hard exudates. You see cystoid spaces, and you see some loss of the outer nuclear layer. So all these things can be picked up in the retinal changes. And here you see a large amount of cystoid macular edema. This is the fovea. So you know this is cystoid macular edema, and in this one there's also neurosensory detachment. Here what has happened, you see it's hyper-reflective. That means now it's reflecting a lot of light. Happens from a scar. So this is a scar tissue which is there. Here, if you look at this layer from here to here, you see it's missing. So this is atrophic degeneration. And here what do you have? A loss of layers. All the layers are missing. So you have all the 9 layers of the retina missing. You have a macular hole. On the other hand, here it's cutting through, but the last layer is intact. The RPE photoreceptor is intact, which means this is a lamellar macular hole. And at the subretinal level, you can have subretinal fluid, RPE detachment, choroidal neovascularization, like you see over here. You have a RPE detachment here. You have a depression. This is a foveal, this is a focal choroidal excavation. What you see here is an RPE rip. You see the RPE is cut over here. From here to here, there's no RPE. That's a rupture in the RPE. And here, from here to here, if you look at it, it seems that the ISOS junction is missing. The photoreceptors are absent. There's a thinning happening over there of the photoreceptors. Now, OCT can be used. You can see how many things you can pick up in the OCT. You can use it to characterize your lesions for diagnosis, for treatment, for follow-up, for prognostication. Let's see how. Say, in macular degeneration, what all can you see? Now you see these irregularities. These are drusen. So you can pick up drusen. There's no exudative ARMD. You know, just needs follow-up. But see here what has happened. This layer is fallen down. So you have a subsidence of the outer plexiform layer in a nuclear layer. It comes down. There is a loss of the external limiting membrane. The ISOS junction is broken over here, and the outer nuclear layer is broken. This is nascent geographic atrophy. This is dry degeneration, doesn't need treatment. But what do you see here? There's subretinal fluid, there's an RPE detachment, and you have a type 1 CNV. This is an RPE detachment with subretinal fluid. Now when the same lesion is above the RPE, like you see over here, there's some scarring here and there's a lesion here. Some granularity here. This is a type 2 CNVM above the RPE. And the third one is type 3 CNVM, which is in the substance. You see it, this yellow. A very small thing, a yellow lesion over here in the substance, going downwards, more clearly seen here, coming into these. So there's a small lesion in the retina, goes down, causes a RPE detachment there. That's a type 3 CNVM, what we call a RAP lesion. Now, you've done this is a patient with the CNVM. Now this is post PDT, those eras. We did the treatment with PDT and you see the whole thing's gone. Now it's gone, but there you see what happens, this line becomes red. That means there's a hypertrophy of the RPE there. CNVM resolved, but some scarring is there. What about this? You have a patient, RPE detachment is there, subretinal fluid is there. How do you monitor? You see the next time, you see the fluid is gone. You follow up, and then when there's a recurrence, what do you see? Intraretinal cysts have come. So you diagnosed, you followed up, you picked up the recurrence. All the things you can do on the OCT. What about this? You had an RPE detachment. You can see this RPE detachment, also seen on the fluorescein angiography. And then over time, this patient rips. You see over here? Now, till here you can see the RPE. Here there's no RPE, and fluid has developed over here. This is an RPE rip. Still needs to be treated. You can't stop this treatment, but now you know the visual prognosis is not as great. What about this? Here you see fovea is thinned out. But you see this round cartwheel thing, it looks like a cyst. It's not a cyst. This is cartwheel-like, it is thickened walls. This is what we call an outer retinal tubulation. Don't start treating these lesions. They don't need any treatment. It's a sign of severe degenerative change. On the other hand, you can also have central serous choroidoretinopathy. Here you have a neurosensory detachment, but what do you see? The RP is normal, except for the small area of an RP detachment, which can happen even in CSR, but the RP is absolutely normal looking. So you know this is not age-related macular degeneration. This is CSR. This is a chronic CSR. Again, nothing's happening to the RP. RP is normal. But there's a little thickening at the level of the photoreceptors. You know, this is called a brush border sign, accumulation of waste products in the photoreceptor outer segments on the outer surface of the retina. Now, one way to confirm, are you dealing with CSR, is to do the choroidal thickening, check of the choroidal thickness. You can see over here, this is done by what we call enhanced depth imaging. And what do you see over here? The choroid is very thickened. This again has fluid, but now again RP is normal. And what do you see? This is raised in one side in the horizontal scan, but in the vertical scan it's straight. This is a condition called dome-shaped maculopathy, occurs in very high myopes, not a treatable condition. So you need to recognize it because you otherwise will keep on treating it. This is a patient who has a lot of exudation, and this excessive exudation or excessive hemorrhage in a patient who's around 50, 60 years old is a sign of polypoidal choroidal vasculopathy. And what do you see? You see these kind of irregular RPEDs, peaked RPEDs, and then if you look at this RPED, shallow RPED, within that you find another layer. It's called the double layer sign. So this is a sign that there's a branching vascular network under this. These are all signs of a polypoidal choroidal vasculopathy. So any sharply peaked PED, a double layer sign as you see over here, a thick choroid with dilated vessels and some fluid, these are all signs that help you to diagnose polypoidal choroidal vasculopathy. I'm just repeating this. You see this here? This is like M kind of sign. This is again a sign of polypoidal choroidal vasculopathy. But you must also differentiate what we call adult vitiliform degeneration. Here this lesion looks like a CNVM. On angiography, you'll see actually the hyperfluorescence doesn't increase too much. That should give you the first doubt. If you look at the OCT, it looks like that there is some amorphous material there. But if you do a autofluorescence, you find it's hyperfluorescent. So you know you're dealing with. So combination of this autofluorescence with this kind of picture on OCT, you're sure you're dealing with adult vitiliform degeneration, which does not need treatment. And the other condition is juxtafoveal telangiectasia. Juxtafoveal, again, here it looks like an occult CNV. Late phase, there is a lot of leakage in the macula. There is increased hyperfluorescence, and if you look at the OCT, it shows these changes, but these are cystic changes. These are degenerative cystic changes, and this kind of picture is again characteristic of juxtafoveal telangiectasia. Now, as far as what do you see in the retina macula per se, you see this membrane here. This is a blunting of the foveal contour and epiretinal membrane. What do you see here? A macular hole treated and became normal. You can also tell whether your macular hole has a good prognosis or not by doing what we call the hole form factor. You see the ratio of these two layers to this layer. If it is 0.9 or more, you know your hole will close with surgery. If it's less than 0.5, the chances of closure go down. You do a cataract surgery. Patient not improving. Just do an OCT. You see there's CME. Treat this patient with NSAIDs and low topical steroids. This is what you will get. Normal. So, for you to ensure good prognosis for your patient, good outcomes, this is an important thing. Another condition is arterial ischemia or venous ischemia. You see here, there's a CRAO occurring over here. Now let's see what would it look like. This was actually a patient who had a detachment surgery and developed a CRAO after that. Very scary situation. You can see the inner layers become opacified. This is characteristic of a inner retinal ischemia, a central retinal artery occlusion. And then with time, this will go away and the retina will become thinned out. This is the less scary thing, a CRVO, still scary but not as scary. You can see these multiple hemorrhages, and you look carefully, you see this macular edema, neurosensory detachment, and then you treat this patient, becomes all right. You can follow up and stays all right for some time, again develops a reaction, the edema, again needs treatment and improves again. So you can use the OCT for your follow-up after pharmacotherapy. You can see what's happening, you know when to retreat, you know whether to just do a follow-up in these patients. A branch retinal occlusion, not only will you get this edema, but this edema is now localized, either to superior or the inferior quadrant. So it doesn't cross the midline. So if you do a vertical scan and you find that the edema is on one side only, you know you are dealing with a PRVU. So you can actually make a diagnosis on OCT, and then you can treat the patient accordingly. Ladies and gentlemen, in diabetes, there's a lot of patients whom you need to see, and both for diagnosis, treatment, follow-up, prognostication, you need that. The various lesions called drill, subretinal fluid, intraretinal cysts, all these we'll just go through. Now, the commonest thing is intraretinal cystic spaces. They can be small, large, or even giant. Or very large cystic spaces, if they are left to stay for a long time, are associated with a poorer prognosis. So you don't want to do that. Now, important thing is to treat them and see the response, and you can pick that up. You see here, this was a patient who was being treated with anti-VEGF agent, was not responding, finally was given an Ozurdex, and you see the response started coming within a month. Subfoveal neurosensory detachment occurs in 15 to 30%, may be related to either hypoalbuminemia or because of patient having hypertension. They affect the vision much less, but they can. What you see here is a small neurosensory detachment. What you see here are the cystic changes. So you can recognize the edema. Patients being treated, edema became less, developed this neurosensory detachment, was still treated, everything became all right. So you know how to stop treatment, when to stop treatment in your patients. An important condition which you need to recognize, because this can sometimes cause poorer vision in your patients, is called disorganized retinal inner layers or drill. See, if you see this area here, all the layers are seen. Here, these layers seem to be clumped into an amorphous material. This lack of ability to segment the boundaries of the ganglion cell layer, plexiform layer, inner nuclear layer, these are all a sign of drill. This is how you diagnose drill. Now, this is in the central 1 millimeter, and if we know that if more than 50% of this area gets involved, it's a significant poor prognostic factor. And this is a very reliable factor for prognosticating a patient with DME. Supposing you have a patient, doesn't have too much edema, and has this drill, now you know this patient may not improve as much. Okay? But don't talk about drill in the presence of a lot of macular edema. Because if there's a lot of macular edema, it can push the retinal layers. And that can give you a false appearance of drill. Now, just to show you, here there was fluid. It looked like this area had drill, but the fluid went away and the layers became okay. So don't comment on drill while the fluid is there. The other thing is here, lot of big cyst, but no drill. Vision was good. So this is another important factor to keep in mind. The basic parameters which are predictive of good visual outcome include subretinal fluid. It's better than having intraretinal cysts, absence of hyperreflective spots, integrity of the ISOS junction. You may have any amount of cysts, but if the ISOS layer is intact, chances are your patient will have good vision, and after treatment will have a better visual outcome. I'll just show you what hyperreflective spots look like. They basically represent activated microglia. It's an inflammatory change, and more hyperreflective spots are associated early recurrence after a steroid implant. So these show all the things, the subretinal fluid, intraretinal fluid, and what you see here, these are hyperreflective spots. What you see here, even more clearly seen, these are hyperreflective spots. Now, just to show you, this patient, you can see the ISOS junction is intact. Despite these cysts, good prognosis. This patient, the ISOS junction is gone, poor prognosis. Finally, remember, in our country, we want to decrease the number of injections. You want to know whether I can laser my patient. A retina map can tell you, see this? I know the fovea is spared, the macular edema is away from the fovea. This patient with a combination of anti-VEGF agents and focal macular laser will do very well. So this is what you can get if you do the thickness map in these patients. One more tip for you. When you see these kind of processes, these are called bridging retinal processes. These are basically Mueller cells, so they are lying this area to give the nutrition from the lower to the upper, from the outer to the inner retina. It's a good prognostic sign. If you have these, patients are likely to do well. So ladies and gentlemen, I've taken a lot of time, but basically OCT is the workhorse for retinal disorders. Diagnosis, management, follow-up. It's non-invasive, sensitive, and provides a detailed insight into the pathoanatomic changes that occur in the retinal microarchitecture and has revolutionized the management of retinal disorders. Thank you very much, ladies and gentlemen. And without any further waste of time, I'm going to ask Dr. Venkatesh Ramesh to come and tell you about the last word in OCT, which is OCT angio, and that is the cutting edge, and he's going to tell you more about it. And after that, if there's time, we will